Thank you. I want to thank Marissa and the MDA team who actually put all this together, and there was a lot of work behind the scenes, and also Dr. Bandy from Penn State Hershey, who also put together a large part of the program. But I just want to spend a couple minutes introducing our keynote speaker, Dr. Gil Wolf, who joins us from Buffalo, where he is the Irwin and Rosemary Smith Endowed Chair of Neurology. I think we're really lucky to have him because he's one of the top authorities in myasthenia gravis in the world. If you ask any of us in myasthenia who would be the top 5 people in the world in myasthenia, I think Gil would be one of the top 2 in everybody's list. He actually began his career in neurology at the University of Pennsylvania. And I can prove that because this is a picture from 26 years ago. Sorry. It's a little hard to see. I'm trying to find out how the pointer works here. That's not working. Anyway, he's in the top middle of the picture, and the embarrassing thing to me is that after 26 years, other than the little gray hair, he doesn't look much different. I actually missed this picture, and I'm thankful because you'd see I don't look anything like I did 26 years ago. But Gil hasn't aged much, and so I'm not sure exactly how he does that, but maybe he can tell us. He left Penn to start a stellar career in myasthenia gravis in the neuromuscular field. He went to University of Texas, where he was director of the myasthenia gravis clinic for about 17 years, I guess it was, and then moved to Buffalo to become chair in 2012. At Buffalo, he was named the University at Buffalo Distinguished Professor in 2017 in recognition of the fact that he has become an international leader in neuromuscular disease and in specific myasthenia gravis. His main research interests are in myasthenia gravis and peripheral neuropathies, and he's authored more than 120 papers and more than 20 chapters, and most of them are related to myasthenia gravis. But what I really want to emphasize is his achievements in the field of myasthenia gravis are really too numerous to mention, but throughout his career, he's really been in the forefront of advancing the care of patients with myasthenia gravis and also clinical research in that field. He's the immediate past chair of the Medical and Scientific Advisory Board of the Myasthenia Gravis Foundation of America. He co-directs the MDA Clinical Care and Myasthenia Gravis Clinic Center in Buffalo. But there are 2 recent things that really emphasized his leadership in this field even more. His landmark study examining the benefits of, that picture again, examining the benefits of thymectomy in myasthenia gravis, showing definitively and for the first time the benefits of thymectomy in patients with myasthenia gravis. This was published in the New England Journal of Medicine in 2016, and he was really the force behind this difficult study to do that lasted probably 10 years to get it done?
Longer.
10 years. And then I think even for many of us in the field taking care of patients, he was co-directed an expert panel that published the first international treatment recommendations for patients with myasthenia gravis in 2016, which is a consensus of all the experts in the field around the world as to what would be appropriate for patients with myasthenia gravis in various settings. And for these efforts, the Myasthenia Gravis Foundation of America awarded him the Doctor of the Year award recently. So I think it's a great treat to have him here as the keynote speaker, and I want to thank him for coming back to Philadelphia. Gil.
Thanks. That was really nice. That was really nice. I love that picture. Thanks. Can people hear me? I feel like I'm the CEO of Apple with this with this cool mic. I don't think I've ever used a mic, but can people? I have a pretty loud voice. Everybody can hear me. Okay, great. Well, I'd like to thank Dr. Bird and the other organizers, Marissa, Ed, for inviting me. I like talking in these kinds of settings. I've done it a decent amount, both in the United States and Canada. I like seeing patients with MG all over. I've seen patients with myasthenia gravis in South America now, Israel. But I enjoy talking at these patient conferences, and I'm going to try to make it interactive. The slides are sometimes complex, more complex than I'd like them to be. I'm not going to talk about every single line on the slides, but they can be shared, and so the MDA has them if people actually want the slides to look at later. I don't mind that at all. Okay, and so let me see if there is a laser pointer, or if I have to do it off of this. Oh, I can do it. Is the arrow showing up? All right, so which button is it then? The very top one. Yeah, okay. Can everybody see that pointer just in case I need to use it? Okay, I'm going to use it now. That's our new medical school building downtown in Buffalo. I've just met some people, Phil and others from Syracuse, which is a neighboring city. Who here has been to Buffalo or Rochester, Syracuse? Oh, good. Oh, excellent. Well, come visit Buffalo. Niagara Falls is not too far away. I live actually right here in that building right there near downtown. Buffalo is much less expensive than Philadelphia, much, much less expensive than New York and Boston to visit around, and there's some amazing architecture if you're into Frank Lloyd Wright. We have some of his masterpieces there. Buffalo was the wealthiest city in the United States a long time ago, about 100 years ago. It actually was the wealthiest city per capita because of the grain that would come across, initially because of the Erie Canal and then the railroads, but the St. Lawrence Seaway, which was built between Lake Erie and Lake Ontario, which is a canal system, the Welland Canal, that pretty much ended Buffalo's prominence in transporting half of the grain grown in the United States. That's what it used to do. Anyway, so it's fun living in Buffalo in some ways until the winter comes. These are my disclosures, and there's quite a few of them that come into play. Now, I'm not going to talk about older therapies. I think Dr. Bird is going to talk about some of that, and hopefully some of the other talks. I'm going to talk about sort of newer stuff that's going on mostly. And it does get a little complex, but I'm going to try to explain it as best I can. And just a quick summary, and I hope this gets covered in other areas as well, but this really, myasthenia is our most common sort of defined disorder of neuromuscular transmission as a disease state. It certainly is. There's a lot of medications, by the way, that can impair neuromuscular transmission. A lot of that is subclinical. You don't really notice it clinically, but that may actually be the most common issue we have with neuromuscular transmission or different drugs. But as a disease state, myasthenia is most common. It's probably at least as common as 1 in every 10,000 people, but that does make it much less common than a disease like multiple sclerosis or rheumatoid arthritis, other autoimmune diseases. Fatigable muscle weakness, I think many, well, let me just see. How many of you have MG? I know they're family members too. All right, this is a great audience because it's big. I like big audiences. Okay, so I know many of you experience fatigue. It's sort of our classic fatigable disease in neurology. It affects specific muscle groups more than others: proximal, bulbar, ocular, truncal muscles. It's pretty rare to have predominant weakness in hands and feet, although that does occur. We wrote a series of that when I was in Dallas. Dr. Nations was the first author on that a few years ago. Ocular symptoms, very, very common at presentation. Not everybody gets ocular involvement, but most do. 75% or so at presentation, up to 9 out of 10 will have droopy eyelids. That word, who knows the word in medicine we use for droopy eyelid? Ptosis. Who knows the word we use in medicine for double vision? All right, you guys know it. All right, diplopia, all right? So double vision, diplopia, droopy eyelids, very common. Okay, here it says 50% of presentation. It's somewhere around 50, 75%. I think this number is underestimated now because I think we actually have changed sort of the progression of MG by being more aggressive early on. And so I think more than 15% of patients remain purely ocular these days. It's not much higher than that, but I think it is higher than that number in the textbook. And we can pretty much guarantee an MG patient, if you've only had ocular involvement for 2 or 3 years, that pretty much is the way it's going to stay, okay, which is good. It's not great because it's still not good to have ocular involvement, but it's better probably than having problems swallowing and breathing and so forth, okay? We already talked about the muscles that tend to be involved. Bulbar are kind of these muscles here, swallowing muscles, the muscles that control speech, chewing, and so forth. And unfortunately, still 30% of patients can have respiratory weakness, and that's where patients can get in trouble. That's even higher if you have MuSK. If people are willing to answer, who here knows they have MuSK myasthenia? Anybody? I see very few. It's pretty rare. It's only about 5% of all myasthenia is MuSK, but I see a couple hands going up. Respiratory involvement could be more common there. And there's just some pictures. These are actually from when I was a fellow here. And you know, Dr. Bird and Dr. Shotland, Dr. Asbury, Dr. Brandt, this is a legendary neuromuscular group here at Penn, where I trained, and they got me interested in MG. And this is following Hering's law of equal innervation. And what you're seeing is ptosis, again, the word we use for droopy eyelid, with this right lid slowly curtaining down in this young woman. And here, this may not project that well. Here's an older gentleman with myasthenia gravis, and he's trying to look at the pen on the right, and that left eye is stuck because there's a muscle there called the medial rectus, which is innervated by the third cranial nerve, but you guys don't need to know that. But anyway, the third cranial nerve connection to that muscle is screwed up because of poor neuromuscular transmission, so he can't move the eye in. He's going to have double vision, obviously, looking to the right, okay? All right, and so how are we doing with MG overall before we start talking about medications? We do, compared to a lot of other neuromuscular diseases, we do pretty well, but as you'll see, we need to do better. But this is a study that was published now, basically 10 years ago, by David Garope, who was not a neurologist, but he followed tons of MG patients or had records on them for many decades, from the 40s onward, with MG in New York City. And what you could see is the proportion of patients that died, which used to be 30%, say at the time of the, around World War II to the Eisenhower era. Some of you probably remember President Eisenhower. He was president before I was born, not long before I was born. But look at that. See that black bar? It's come down nicely over time. What hasn't changed, interestingly, is the remission rates, which stayed pretty much the same, at least in the way he defined remission. That's, actually having no active disease. It does happen, but it doesn't happen for the majority of MG patients, unfortunately. Even to this day, it still doesn't happen. But the proportion of patients that improved, which is this hash bar, has gone up nicely. So we have made strides over the years, but there's still room to grow. And I'm going to talk now about sort of challenges we have in MG. I saw somebody in the back corner who had MuSK-MG. This is one of Don Sanders' patients with MuSK myasthenia gravis, the less common antibody of the two main antibodies that we see in myasthenia. And this is an African-American woman, obviously, and it's hard to show weakness. She has some droopy eyelids. She's having trouble moving her eyes. It's kind of hard to show that in a static picture. Her tongue actually has some degree of atrophy even in it, some muscle loss in her tongue. This is before she was controlled. But after a year of prednisone and mycophenolate, who here takes mycophenolate? Or has taken mycophenolate? A bunch of you. Okay. Those trials were negative, but most of us think the drug does work. It's just that the trials were flawed in the design. But you can see her tongue filled out some. She can look up much better than she used to. She has better eye closure strength as well. So she did improve. But some of these patients, even with a year of prednisone or mycophenolate, using it aggressively like they do at Duke, they're still wanting as far as disease control. And so this is just an example of the problems we have with MuSK myasthenia gravis in particular, but we have problems with other forms. This is receptor antibody positive, and these are patients who have no antibodies. How many of you here don't think you have antibodies to MG that you've been tested? So a few of you. It does occur in about 15% of patients. But if you look here from this study from Italy, the proportion of patients going into complete stable remission, which means you're off all medication, including even Prednisone for a year, and you have no signs of active disease, your strength is good and so forth, it's only 20%. Again, that fairly low rate of remission in myasthenia gravis. But look at the MuSK proportion. It was less than 5%. It was very, very rare, and that was a statistically significant figure. And so that's one of our challenges, MuSK. But there are other challenges in MG that I'll get to in a slide in a second. This is another example of how MuSK can be difficult to treat. It really doesn't respond very well, for reasons that we're starting to understand better, to anticholinesterase agents. Prednisone is the anticholinesterase agent that many of you are on, but what's in yellow here are significant differences between the MuSK population and other populations of MG. And importantly here, the response to pyridostigmine is much less satisfactory in MuSK than it is in other populations. This is a study that we did with our colleagues at University of Alabama when I was at Duke. And this just shows you of different classes of treatment that were commonly used back then for myasthenia gravis. Rituximab is not in this list. But the MuSK patients, you're talking about 6 out of 10 of them needing 4 of these different treatment categories, meaning that they would have had to have been on plasma exchange or maintenance IVIG as well to control their disease. These are tough patients, these MuSK patients, to treat, okay? And so what does that lead to? That leads to us trying to make efforts to improve therapy. And so this is a new development, and there is a randomized trial, the results of which I've seen and should be published soon. But who here has ever taken 3,4-diaminopyridine? None of you. It's, a few of you there. It's most commonly used in Lambert-Eaton myasthenic syndrome. Is anybody here with, does anybody here have Lambert-Eaton myasthenic syndrome? Dr. Bird wrote a nice paper on that with IVIG a long while ago. But okay, nobody has it. But 3,4-DAP, maybe we should think about using it in myasthenia, particularly musk myasthenia. This was the first case report that I'm aware of by Amelia Evely in Rome, and she had a musk patient. They didn't know she was musk initially because we didn't know about the antibodies. She had a thymectomy, which often doesn't help, and she was still having a lot of double vision, facial and upper limb weakness, problems speaking, dyspnea is problems breathing, okay? She was getting plasma exchange, but it didn't lead to improvement very long. This is after musk, and she was treated with a lot of different medications. And so because there's potentially, I don't want to get into the details, but there's potentially a presynaptic problem, not just a postsynaptic problem, but a presynaptic and musk MG, they decided to try 3,4-DAP, which works at the nerve terminal to improve acetylcholine release. And sure enough, the patient improved, and that led to an actual trial which does show positive results. That's all I'll say about it, which was largely done in Europe. But anyway, because of these challenges, we look for other things. And so where are these unmet needs in MG before I get to some newer medications? All right, so I imagine the number may be even higher in the population because patients who are refractory tend to come to meetings more often, I would say. But clearly it's 5, 10, 15% of MG patients really are refractory, okay? Where just the conventional medications just don't work as well as we would like or as well as the patients would like. So that's an unmet need. I think, and there's some data for this, it's not great data, but there's a lot of patients who are, their disease is reasonably well controlled, but they're having side effects from medications. Prednisone is notorious. Who here has had a side effect from prednisone? Whether it's weight gain or bone loss or stomach issues or even sometimes insomnia. Yes, prednisone is a bear to deal with long-term at higher doses. That's why the Japanese, they have found if you actually can get people on a dose of 5 milligrams a day, that's pretty low, or the equivalent 10 milligrams every other day, there the side effects are really quite minimal. But it can be difficult to get people to that low a level. But there is a good proportion of patients who have problematic side effects, especially with steroids, but that can be true with azathioprine, which is Imuran, or mycophenolate, which is Cellcept, or myfortic acid. Musk MG patients, I've already talked a little bit about their unmet needs. MG crisis, I think, is still somewhat an unmet need. Most patients do pretty well when we give them plasma exchange or IVIG, but there's some patients, their crisis really, it doesn't come around as quickly as we would like, and I've encountered situations, just one recently, unfortunately, we were able to avoid a trach. He finally did come around, but if you're on a ventilator for more than 10 days or so, the pulmonologists and the ICU attendings don't like that because it causes trauma. It's harder to manage with the endotracheal treatment. And I don't want my patients to have tracheotomy. So anyway, that does come up occasionally in crisis situations. So if we had other ways to treat crisis beyond what we have now, I think that would help us if there's other things that we can turn to. And something, at least something that has more persistence after crisis treatment. And then this is a statement from that international guideline that Dr. Bird mentioned, that Don Sanders and I and 15 others put together. And so there's a statement here, and I have this variable here. I'm hoping over time we're going to have a good number of medications, at least a few, that we can place in this XXX. The use of whatever is going to be as maintenance therapy should be considered for patients with refractory MG and in those in whom immunosuppressive medications are relatively contraindicated because of comorbidities or pregnancy. And so we have room to grow in MG. And so now I'm going to start talking about some newer medications. Some of them are not brand new. We're going to start with those that affect the B cells. Everybody here has heard about white blood cells, right? White blood cells are in our blood. Red blood cells is what make blood red. White blood cells are part of the immune system. There's two major types of cells, the B cells, which their descendants make the antibodies, and T cells, which kind of like modulate and control, and also are involved actually with killing things, okay? Like bugs, like bacteria and viruses. Anyway, we're going to start with B cells, okay? And Rituximab, who here has actually been on Rituximab? Because it's fairly commonly used for MG. Anybody here on Rituximab? Yes, a few. Who here has tried Rituximab? All right, so really just very few. Okay, we're going to spend some time talking about Rituximab, and I'll explain why at the end because of what came out in April. Rituximab and belimumab. There's other drugs in addition to Rituximab, like ocrelizumab is now approved in multiple sclerosis. Now, these drugs I'm talking about, except for one, none of them are approved in MG yet. But rituximab works by blocking the CD20 antibody, and it basically makes B-cell populations go away. Okay, they just diminish in size. It actually sort of kills the B cells by blocking this receptor, all right? And B cells, again, are the ones involved with antibody production, and we always think of myasthenia gravis as a B cell kind of mediated disease. That's not completely true, because the B cells and the T cells work very closely together. And, but in any case, if we can get rid of the B cells, that should help MG, and in series at least it has, but we'll get to the controlled trial in a little bit. Okay, and so this is some data. This is from the Spanish group in Barcelona, looking at refractory patients who were either acetylcholine receptor antibody positive or MuSK antibody positive, okay? And look at these results. 10 out of 11 patients improved with rituximab who had the receptor antibody. Every one of their 6 MuSK patients did. And these improvements lasted long periods of time. The MuSK patients only had to be treated for 3 months worth of the rituximab. Nice looking data, from 2012. And then the Yale group just looked at MuSK myasthenia gravis patients, and again, they got very, very nice results in these refractory patients. By the way, most MuSK patients are female, okay? And general MG is more common in women, although older men are making up a larger and larger population of MG pretty much worldwide. But MuSK is really predominantly women. In fact, in Dallas, when I left, we had over 20. I didn't have a single male patient with MuSK MG in Dallas. All right, anyway. Sharon Nations did, but I didn't. Anyway, so 8 of these 9 patients with MuSK were female, and they were able, after giving rituximab in this dose, and they cycled them every 6 months with a repeat cycle of infusions, which lasts basically a month. And these patients did great. 8 of 9 came off all other treatments. And the other one, the one who still had to be on some prednisone, was just on 5 milligrams a day, in that range that the Japanese have found can be compatible with very nice quality of life, okay? So it was tolerated pretty well. So again, not controlled. This is not a formal trial, but it's just their experience looking at patients and going back in notes and so forth. And so Dr. Silvestri, who's with me in Buffalo, this is a few years ago, we actually looked at all the data so far in rituximab, and about 60 patients had been exposed at that time. It's greater now. About half of them were receptor antibody positive, about half were MuSK antibody positive, and that was the most frequently used dose. But nearly all patients improved. The response seemed to be even greater for the MuSK patients than the acetylcholine receptor antibody positive patients. But everybody seemed to be doing well, and it was generally well tolerated. No opportunistic infections. That's one thing we worry about with some of these newer drugs, that you get into weird viral infections and so forth. And so that led to, all right, we're going to study this formally, and NeuroNext is a NIH, our tax dollars supported, the National Institutes of Health, through the NINDS, which is one of the branches of the NIH. They support this clinical trial network. We're part of it in the SUNY system, our 4 SUNY campuses across New York, and there's 24 other sites. And they recruited only receptor antibody positive patients. I thought they should include MuSK patients, as did many other people, but they just decided statistically to keep it as pure a population as possible. They recruited 50 patients. Richard Nowak did a great job. He's at Yale, where John Goldstein used to be. Actually, I know one of you is followed by Dr. Goldstein in New York City. Anyway, they recruited patients with active disease. They had to be on a reasonably high dose of prednisone, at least 15 milligrams a day, or 30 every other day. And they allowed patients who were on mycophenolate or tacrolimus or Imuran to stay on those types of medications through the trial. And they looked for a steroid-sparing effect. Could they get these prednisone doses down? And all of us, I think, were hoping the study was going to be positive. We want studies to be positive when we're putting patients through trials and so forth. But unfortunately, and this was just announced in April, it hasn't been formally published yet, but it was announced at the American Academy of Neurology meeting earlier this year. And they had 52 patients. And the primary outcome response rate, what they were looking for is reducing prednisone by 3/4. And it did not show an effect for the rituximab versus the placebo. Now, part of that, I think it was pretty easy to lower prednisone in this trial. Patients just had to be stable. And there's just something about putting patients in trials. They often stabilize or are doing pretty well. I think that's partially the doctors and the patients wanting to be hopeful. So it was easy to lower prednisone on both arms, basically, is what ended up happening. And it ended up, this was a futility organized study. It did not show a significant benefit for rituximab in lowering prednisone. And sure enough, also, when they looked at other outcome measures, the MG composite or the QMG, where a reduction in score is an improvement in disease status. And it looks somewhat better for the rituximab on both of these scales. There was a greater reduction. 5.7 is more than 4, 3.95 is more than 1.7. Again, a negative number is good here, but it was not statistically significant. There you go. So, where are we going to go with rituximab? This has not been formally published yet. I hope it doesn't create issues in trying to get the drug approved. There's quite a bit of data that does seem to show, like I showed you, that it does work, but in a formal trial, it did not show a steroid-sparing effect. But this is just another study I want to show you that was published quite recently, where they were looking at MuSK patients, and they did this in a blinded prospective review fashion, so they actually matched patients and tried to pretend it was sort of a randomized trial, and they had blinded assessors. Dr. Silvestri in our group was one of the blinded assessors looking at medical records, so to try to remove bias. And they had 55 MuSK patients, and they used this new, Michael Hare is at Vermont, and he's very interested in trying to improve our outcome measures. So what he did is he combined what we've been using for a long time, which is a post-intervention status by the Myasthenia Gravis Foundation of America, and combining that with medication needs to see if the rituximab helped reduce other medications to lower doses in MuSK patients. And he was calling a level 2, which required minimal manifestation status. That's a patient who's still on medication for MG, may have tiny bits of weakness that we can pick up on exam, but the patients really are doing quite well functionally. They can work, they can exercise, they can do what they want to do, basically, okay? And what I want to show you here is this is the initial, before they analyze patients on rituximab, so this is the control, and anything that's green or to the left is good. That's a good outcome with this thing that he came up with, this myasthenia gravis status index. And so what you can see here is those patients who are on rituximab versus those with MuSK-MG who didn't get it, the green to the left, look at that proportion. It's much smaller than that proportion, and that was statistically significant, okay? Of patients, so more than half met this pretty strict outcome versus only 16%, 58 versus 16%. And then he looked at prednisone doses, and the prednisone requirements were also less if they got treated with rituximab. Again, an indication, at least in MuSK-MG, this drug can work. But unfortunately, we're stuck with this negative study in the receptor antibody positive population, and we'll see what the ramifications are, and if the companies want to look further at CD20, this mechanism of action. Now, I want to turn very briefly to eculizumab. Who here has been on eculizumab? Nobody here. All right. This is only for receptor antibody positive patients because of the way it works. So eculizumab works in the complement system. And the complement system is kind of driven by other white blood cells, particularly the B cells that create an IgG, that's antibodies, of the IgG1 and 3 class. They activate complement, and we know it's very important in creating and in causing the destruction of the muscle membrane in MG. So if you have receptor antibody positive MG, it is likely that at some point in your disease state, you had pretty bad destruction of your postsynaptic membrane. That's the muscle membrane. And that's what we're trying to repair to improve where the receptors are and improve neuromuscular transmission. So if we can block this complement-mediated injury, okay, with a drug, we could very well help MG, and that's what's been found. And this drug, as of just over a year ago, has been approved, and it's the first drug approved in myasthenia gravis that's an immunotherapy. This is the only one still. It's very expensive, unfortunately, but it has been shown to be effective, and I'll show you that data, okay? So this is a monoclonal antibody. It binds the C5 component of the complement, and basically what that does is it prevents C5 from splitting into C5a and C5b, which is just parts of C5. And C5b is what sort of starts what's called the membrane attack complex formation, and that membrane attack complex, it attacks a lot of things, but one thing that it can attack in myasthenics is the muscle membrane, the postsynaptic membrane. It's already approved for a couple of other very rare human diseases that are not neurologic. But Dr. Howard has run the phase 2 and phase 3 studies. Again, other forms of MG we don't know have this kind of complement-mediated injury, so it's not applicable except in the receptor antibody-positive patients, and it's generally thought to be one that we're going to use for refractory patients, although it has now a label from the FDA that just basically says generalized receptor antibody-positive disease above age 18. And so this was the initial crossover study, and without going through too many details, the dose they used was somewhat lower than the phase 3 study that I'll show data from. But what they saw is the MG-ADL, which is another one of these scales that we actually developed in Dallas. I wrote the initial paper on that scale, but it showed a significant improvement for eculizumab versus placebo in a small population of MG patients. And so what ended up happening was this phase 3, sort of, this monumental study to see if it worked, and then it's set up so the drug could get approved by the FDA. And sure enough, they recruited 125 patients. It lasted a half a year, and those were the doses. It starts at 900 milligrams a week. It's given intravenously. It's a fast infusion. It just takes 25 minutes, okay? And then after that, you get 1,200 milligrams every 2 weeks. So as far as we know, this is something that people will stay on a very long time. Maybe we'll be able to space the dosing out over time, but it's labeled as 1,200 milligrams chronically every 2 weeks, okay? And I don't want to get too much in the statistical analysis, but their primary outcome, which we used, there's different ways to analyze data that statisticians use, and they used a very tough one called the worst rank analysis, and it did not meet a statistically significant, it barely missed it. If this had been 0.0498, it would have been statistically significant. But anyway, they had other endpoint analyses that were planned, and pretty much everything else showed a significant improvement for eculizumab versus the placebo in this tough study of very tough MG patients, refractory MG patients who had failed several therapies for at least a year on each of those therapies at good doses. These were tough patients, which may be true of some of you in this audience. And so this drug was approved. And this is just some more data. What's in blue are the eculizumab patients. What's in red are the placebo patients. And you can see improvements, which are drops again in these scales, whether it's the MG-ADL, that's the activity of daily living scale, or the quantitative MG, which is pretty much our oldest scale that we use commonly these days. But it favored the eculizumab versus placebo. There are placebo responses in every trial, in MG, pain studies, depression studies. There is a placebo response, but there was a statistically greater proportion of patients with these different point drops on these two scales with the eculizumab. Again, at a statistically significant level with those what's called p-values. All right, so that's intravenous. It's not easy to get an intravenous drug every 2 weeks. It's also very expensive. We're part of a study now, and are you, some of the sites here in Hershey or Philadelphia may be involved with this. We have just completed recruitment. We got a couple patients into this trial. This is a subcutaneous form, basically, of eculizumab. It's a different company. It's a different molecule, but the same idea, blocking complement. And we're going to see very soon if these two doses, we're trying 2 different doses, subcutaneously, it's given every day, okay? And we're looking at the change in the quantitative MG score and some of these other commonly used outcomes in MG of these 2 doses versus placebo, again, in patients who have active disease with, again, acetylcholine receptor antibodies. Again, this class of drug is probably only going to work in that group of myasthenics. And we'll see, because sub-Q daily, it's just a very quick shot, like giving an insulin shot. I thought some of my patients who were not used to giving shots might have some issues, but after one training, basically, they got it. And so we'll see what that shows. Okay, so that's eculizumab, that's rituximab. I didn't talk about belimumab because the trial was negative. It was looked at, it's another B-cell acting drug. So we've talked about B-cells, we've talked about the complement system. I want to move now to things that are more T-cell, well, actually I'm going to talk about FcRn antagonists, and then we'll talk about T-cells briefly. But, so, there are a bunch of companies, both big pharma and smaller pharma companies, so really large companies and companies that are sort of startups interested in this mechanism in MG and in other diseases. But when you have antibodies, they get circulated. they get recycled sort of, and that's done through this FcRn receptor. And if you block the FcRn receptors, again, on the B cell side of things, you can keep the antibodies present in the circulation. If you block that receptor, that recycling ends, and so you're going to reduce antibody levels, okay? Kind of similar to what we do with plasma exchange, but this is a drug, not an exchange system, okay? And so it blocks IgG rescue, and this company, this was the first trial that has released data, although there's other companies, again, interested in this. This was argenx. It was a phase 2 study of a drug they've now named efgartigimod. It was positive. I'll show you the data. It looked pretty good. It was small, 24 patients getting 4 weekly 10 milligram per kilogram infusions, so once a week times 4. And they were assessed out to basically 3 months. And the results, again, were just released at the American Academy of Neurology meeting in April. And it was well tolerated. In these earlier studies, you want to make sure the drug is well tolerated. That's a key focus, obviously. It's a focus for all trials, but especially early on. And then they looked at outcome measures for efficacy, and they did see, versus the placebo, a higher proportion, 75% of patients had at least a 2-point drop on this MG activity daily living scale versus only 25% on placebo. Again, a placebo effect, but that was statistically significant. And then a few of the other scales at different time points also showed a benefit of getting efgartigimod versus the placebo. And so this is a first indication in a trial in MG of this mechanism of action potentially being useful. And it works fast. You see responses quite quickly with this mechanism. So we'll see where this goes, okay? And they're planning larger studies. This company is planning a phase 3 study right now. Okay, now I'm going to talk about things on the T cell side to some degree. And so these are mostly case reports, but just food for thought. This is tocilizumab, which blocks the IL-6 receptor and could reduce autoantibodies as a result. It's been approved for a couple of diseases. It does have a few side effects to worry about, but these were 2 women with very refractory receptor antibody positive disease. They had thymectomy and so forth. They've been treated with all these different things. They did get rituximab even, which I know nobody here has gotten seemingly except a couple of you, but they got fairly low doses of rituximab in my view anyway when I looked at it. But these patients did very, very well after getting this IL-6 receptor blocker, okay? And so we'll see if there's any interest in this mechanism of action in MG. And then this was seen by happenstance, basically, okay? This is another drug more on the T cell side because it blocks this pathway that drives differentiation of CD4 positive T cells. And it's been approved in myelofibrosis, and that's why this woman with MuSK-MG got it, because she also had myelofibrosis, and she had failed the standard treatments for the myelofibrosis, so they gave her this drug, and her MG just completely normalized, basically. Her single fiber, which is a study that how many of you have had a single fiber EMG? A few of you. Her jitter, which is what we measure on single fiber, normalized. Her MuSK antibodies went away, and all her MG weakness resolved. So perhaps this is another pathway that we'll look at in the future. Okay. Who here has gotten subcutaneous IG instead of intravenous? Very few of you, but a few. This is a study, and there's a lot of attention. We've been part of a study in this as well that CSL is doing, but other companies are interested in it as well. This is a study that was just published a couple of years ago looking at subcutaneous IG at that type of dose, 20 grams per week in 3 of these 9 patients with myasthenia gravis. And then a few others got a somewhat higher dose than their IVIG dosing had been. So a lot of times people are looking to convert patients from IVIG to subcutaneous because you can actually deliver the subcutaneous yourself. It frees you up from having to be at home with an infusion nurse or going into an infusion center to get the IVIG. And sure enough, they saw improvements. All patients were stable to improved in clinical class. Their outcome measures improved. Subjective responses improved as well. One advantage of this, who here gets IVIG and has headaches from it? A few of you. There's very few headaches seen when you give it subcutaneously, okay? So this is another thing that could benefit our patients, especially those who have side effects or have lifestyles where waiting for intravenous infusion is just not good. And I'm just going to briefly mention this because this is heavy-duty therapy that's being done in Ottawa not far from me in Buffalo, and they're actually doing stem cell transplants, autologous, so drawn from the same patient, and then they have to give them Cytoxan, total body radiation. You're basically doing a bone marrow transplant type system like you would in patients with bad cancers that are not responsive to other forms of therapy for their cancer. And these are very refractory patients, but you get nice responses, but you have to deal with potentials of infections, and but this is another potential approach that's not just being looked at in MG. The same center in Ottawa also does this in multiple sclerosis patients. So the worst of multiple sclerosis patients, they consider doing bone marrow transplants. Neurologists cannot do this on their own. In fact, we're pretty peripherally involved. It's the oncologists that have to do this because, patients are basically lose their whole immune response for a while until it gets rebuilt, and you're very prone to infections, and you can die from sepsis and other things. Okay. Dr. Bird briefly mentioned this. I just want to say that thymectomy, and I'm not going to go because I'm running a little bit short on time, but we did do the thymectomy trial. It did take us a long time. It was an international effort. The results were published 2 years ago. The results from the extension study are at a journal right now, and I think it'll come out soon. But what we were able to show with thymectomy in receptor antibody positive patients who got the thymectomy within 5 years of their disease starting, okay, and were between age 18 and 65, that the prednisone requirements went down significantly, and their outcome from their disease status, looking at their quantitative MG score, that was actually the prior slide, this is a quantitative MG score improvement, and this is the prednisone requirements, both favor the thymectomy arm versus not having thymectomy. So this proved what we had felt was true, at least many of us, for many years, that there is benefit for thymectomy, not only if you have a thymoma, but if you just have either a hyperplastic thymus, and I don't want to go into detail, but it's potentially helpful even if there is no evidence of thymic hyperplasia when they take the thymus out. We actually have seen that. We're getting to that as far as the publications and so forth. But thymectomy does improve status from the disease, and I think it should be heavily considered in receptor antibody positive disease fairly early on in generalized patients, especially if the initial attempts at immunotherapy have not been effective. And what I'll just show you without going through detail, all these things in red were statistically better for the thymectomy arm than for the non-thymectomy arm. All these numbers in red for all these different outcomes we looked at, prednisone requirements, their quantitative MG score, their MG-ADL scores, the proportion of patients in minimal manifestation status at given times, it all favored thymectomy. I think the story is pretty clear. You don't see a lot of trials with this much weight in one direction. So anyway, and as far as side effects and hospitalizations, we also saw benefit for thymectomy versus the non-thymectomized arm. As far as needing to be hospitalized over a 3-year period after the thymectomy for MG crises or exacerbations. And then I'm going to finish up again, and this was also mentioned by Dr. Bird. These were all the people that were involved through numerous continents, Asia, Europe, and so forth, to put together a treatment statement. And it's not that hard to understand. We wrote the executive summary so it could be understood even by non-neuromuscular neurologists, non-neurologists, and so forth. And we did cover all these different categories of treatment. Symptomatic, that's Mestinon basically, and immunotherapies, IVIG and plasma exchange, this particular treatment issues in MuSK-MG, thymectomy, myasthenic crisis, childhood MG, and for women who are pregnant with MG, what the best approaches are for now. And it includes some tables on dosing and stuff, so I think it's been helpful. And with that, I'm done. Thank you.